Hi, this is Dr. Joannides, Chief Medical Director at Optimum Re. Today we're in the Optimum Academy with Pulmonary 101, video number 7 on tuberculosis and sarcoidosis. So let's get started. So pulmonary tuberculosis is due to Mycobacterium tuberculosis. Humans with active pulmonary tuberculosis are the source of new cases of Mycobacterium tuberculosis cases. In 90% of cases, the body contains the M. tuberculosis bacteria as an asymptomatic latent TB infection. And in those people, there's a positive skin test, but a negative chest x-ray. And they may be treated with a drug called isoniazid or INH for 6 to 9 months to eradicate those latent TB bugs that are in the lungs. So these people have an infection, but no TB disease. So they're at low risk as a mortality risk as long as the infection remains latent or if it gets treated with isoniazid for this period of time. So that's latent TB infection. There are multiple drug-resistant TB in the world, and that's because these bugs have either been poorly treated or ineffectively treated, or people have not taken their medication correctly. So you can see that the multiple drug-resistant TB that's in the world is in the Soviet Union and in Asia, whereas in other Western countries, you're much less likely to run into that kind of a problem. And here's an idea of where new TB cases are coming from. So the continent of Africa, Asia, South America. I don't know how many cases are actually coming from Greenland, but it's also shaded in dark there. How do you do a TB skin test to see if somebody has latent TB disease or infection, I should say? So you have to appropriately place the needle at the right depth in the skin in order to do a skin test. So it's not as easy as it might seem. The needle has to be placed exactly in the right level of the skin, and it has to be measured between 48 and 72 hours after the medication the PPD medication is put into the skin. And you measure the indurated area, not the red area, but the area that feels like a mosquito bite. So that's the area that's measured. And usually if it's over a centimeter, that's a positive test. There are also blood tests that can be done to see if somebody has latent TB infection. They're called IGRA tests, which stands for interferon gamma release assay. And it measures how the immune system reacts to the bacteria that causes TB. The typical one we see used when we look at an APS is called quantiferon TB gold test. There's another test called the T-spot, but most of the time I see quantiferon TB gold as the test that is used. And so a positive blood test means that the person has been infected with TB bacteria, but you won't know if that test is positive, whether they have latent TB that we already talked about, or which is the latent TB infection, or do they have TB disease? If someone has a negative IGRA, it means the person's blood did not react to the test and that latent TB infection or TB disease is not likely. So IGRAs are becoming the preferred method of TB testing because some people have received a TB vaccination called BCG, which confuses the issue if you have a skin test, a PPD skin test. So that's one reason that these blood tests might be used. Also, some people have a difficult time returning it at exactly 48 to 72 hours after their skin test was applied. It may not be read correctly, so there's problems with the skin test. So a lot of people are turning to IGRAs as the way to detect latent TB infection or disease. You will note that when people get biologic drug treatment like Humira or some of the other drugs for a number of diseases like rheumatoid arthritis or psoriatic arthritis or inflammatory bowel disease, all those diseases may be treated with biologic drug treatment. Before they get treated, they should be tested to ensure they don't have latent TB, since those biologic drugs may allow latent infection to become disease. So here's the difference between latent infection and active disease. So latent infection means that you've been exposed to the TB bug somewhere. It's taken up residence in your lung, but it's not causing any trouble. It's just hanging out. Your skin test, the PPD-S skin test, would be positive, but you'd have a negative sputum culture and a negative chest x-ray. It's just the skin test is positive, or that IGRA test we talked about is positive, but no evidence of disease. Whereas active disease from TB, you're exposed to the bug, but the body's unable to contain the TB bug in the lung, and it gets out of control. It starts causing a more aggressive infection. And in addition to having a positive skin test or a positive IGRA test, you're going to have positive sputum cultures for TB germs and a positive chest x-ray, which is going to show an infiltrate or even a cavity on a chest x-ray. So that's the difference between latent infection and active disease. So again, to the left, skin test, positive. You measure the indurated area like the mosquito bite. If that's positive, but no sputum culture is positive or no chest x-ray is positive, you just have a latent infection. Whereas on the right, this chest x-ray shows a TB cavity, which has TB bugs in it, and it shows a TB infiltrate in the right upper lung. So this is active pulmonary TB disease. Now, this kind of tells you like the difference between the two using a picture of teenagers. Latent infection is when everyone's just kind of hanging out, but everything's under control, whereas active disease, you can see the picture to the right. So, underwriting TB. Low risk or favorable consideration would be someone who has a positive skin test. They've been put on INH, the medicine, isoniazid, for 6 months, but they have a negative chest x-ray. They're treated for the positive skin test, and everything turns out just fine. That would be low risk. Or they may have a positive skin test, scarring on the chest x-ray from old TB that was adequately treated, but they're in good health. No evidence of any active disease on serial chest x-rays, so everything looks okay. Or they had prior active tuberculosis, treated by CDC guidelines with resolution of disease and good follow-up, which is negative for any continuing or advancing disease. So those would all be in the low risk, favorable consideration category. High risk or unfavorable consideration would be active TB, where the applicant is not compliant with medication, active TB with positive sputum samples when they're checked at certain intervals, active TB with spread of disease while on medication, or active TB with multi-drug resistant TB organisms, or TB that actually gets outside of the lung and extends to other areas of the body like the spine or other areas, or active TB in an immunocompromised applicant, say somebody that's HIV positive and maybe is not taking their medication correctly and also has active tuberculosis. Those would all be the high risk categories. So here's a case, underwriting latent infection. So a 28-year-old man was hired for a lab job at the CDC, and as part of his employee testing, he was found to be skin test PPD-S positive. So he has no symptoms, no past medical history, and never had pneumonia or TB, and has lived in Atlanta, where the CDC is located, his entire life. A chest x-ray was done and was negative. He had no evidence of an infiltrate or a cavity. So he was started on isoniazid INH and has completed 5 of the 6 months of his treatment with no side effects. And sometimes the INH can cause elevation of liver enzymes and other things along that line. So in this case, he's being effectively treated, so he's a very low risk as far as underwriting for a life policy. Another case, underwriting active pulmonary TB, also a 28-year-old male, recently immigrated from a country where TB is endemic. In other words, there's a lot of TB where he came from. He had received BCG vaccination as a child and now has a positive reaction to PPD-S. Now, we said that some people that have received BCG vaccinations get that blood test to help determine whether they have active infection or disease. But this person has a chronic cough, and he has not sought treatment for it. And a chest x-ray shows a right upper lobe infiltrate with a cavity. The biopsy of the affected lung lesion showed caseating granulomas, which are typical of tuberculosis. And although sputum tests for TB are pending, he was already started on 4 drugs for TB since he came from a country where TB is endemic. He appears to have TB, so you don't wait around. You start the medications right away to try to get a handle on tuberculosis. Excuse me. So this is an x-ray, again, just showing the difference between a normal looking chest x-ray on the left, and when we look at an x-ray, we look at the x-ray as if the person is looking at us. So the left lung is on our right and the right lung is on our left. But you can see the dark 2 areas to the right and left are the lung tissue, and the ribs go across it in bands, and then you can see the heart in the middle. You can see the diaphragms at the bottom. And to the right is a chest x-ray which shows that TB cavity again and the pulmonary infiltrate in the right upper lobe. So you can see that's shows, in this case, active pulmonary tuberculosis disease. Now you can see the amazing effects that TB drugs have had. Prior to the 1950s, there was no medication to treat tuberculosis, so people were put in TB sanitarium, and all they got was sitting in the sunroom or the solarium to try to get some help with their tuberculosis. But through the 50s and 60s, new drugs were developed, and you can see not only did the cases drop, but the number of deaths due to pulmonary tuberculosis dropped significantly. So it's due to the development of new drugs that really saved us. So there's a lot of different tuberculosis treatments that are either over a longer period of time or developed on a more short-acting dosing schedule for shorter periods of time. So you can refer to the CDC for different treatment guidelines on whether a short or long acting period, a shorter or longer period of time that the drug should be used, or if the drug turns out to be drug resistant, a certain extra combination of drugs may be needed in order to get it under control. And then for latent infection, not disease, but just latent infection, you can see there are different options available for that as well. So what are the takeaways for tuberculosis? We talked about latent infection versus active disease. We talked about the skin test or blood test we can use to see if somebody possibly has latent infection or active disease. We talked about pulmonary TB treatment with 4 drugs, then possibly 2 drugs, depending on what the type of TB is and if it might be drug resistant. And then we talked about high-risk diseases, things like disease that goes outside of the lung, so extrapulmonary disease or disease in an HIV or immunocompromised applicant. Now, sometimes you're not sure whether an applicant or a patient has TB or sarcoid disease because they may have infiltrates that look somewhat similar. So you want to do a flexible lung biopsy. So you use a flexible fiber optic bronchoscope. As shown in the bottom left, you actually place the tube into the person's breathing tubes, and then in the affected area, you take a biopsy to see what actually is going on in the tissues. And this has been a great invention to use these flexible scopes. In the good old days, the bronchoscope was actually rigid, so it was like swallowing a sword, and the doctor had to take a biopsy using that long, straight tube. People usually didn't come back for a second one of those. So here's a difference between tuberculosis and sarcoidosis. In tuberculosis, it's typical to find what's called caseating granulomas. In other words, that red circle to the left is actually, see how it looks kind of cheesy in the middle? And caseating means cheesy, so that's a cheesy granuloma, and that's what you find in tuberculosis. Whereas in sarcoid, the slide to the right in the purple, that doesn't have that cheesy middle, so we call that a non-caseating granuloma. So the pathologist would be able to determine whether that infiltrate was due to non-caseating granuloma in sarcoid to the right, or caseating granulomas, as in TB, to the left. So sarcoidosis is a granulomatous inflammation characterized by granulomas or small clumps of immune cells in various organs. It can affect the lungs, the skin, eyes, lymph nodes, other organs. It's due to an unknown cause. We still don't know what triggers it. It has a variable presentation. It can be asymptomatic or severe organ involvement. But common symptoms include persistent cough, shortness of breath, fatigue, skin rashes, and swollen lymph nodes. And it often presents in the lung. So often on a chest x-ray, somebody will be noted to have increased size of their lymph nodes or some kind of either inflammation or interstitial lung disease, or possibly even nodules in their lungs associated with pulmonary symptoms. So it's a diagnostic challenge because there's not really other tests you can do besides getting a biopsy that will help you determine exactly if this is sarcoidosis. It can affect different systems, organ systems in the body. So maybe a group of specialists need to take a look and see if something is typical of sarcoidosis, of either in the lungs, the skin, eyes, or whatever. Sometimes it can resolve on its own, go into spontaneous remission. Other times, steroids are often prescribed to manage the inflammation in sarcoidosis, or other immunosuppressive medications may be used. So that completes our video on tuberculosis and sarcoidosis. We have a few more videos in the Pulmonary 101 section of our Optimum Academy, so stay tuned for those.